Is anybody joining? I don't know if anyone is. There's no one else. Okay, do I need to leave or you'll be here?
It's really hard to present that about being most systems. Yeah, also in the name was. I think sure. Sure, I think it is. I'm getting now. Take girls with additional families. Oh, I know. Now, I don't want to show that. I could say like yeah, I've been sitting going there sometimes. So that's before I can see it, like, that's very important. Yes. So I'm just saying,
I'll say that.
No, this is road. If I stand. I sit over here. But I'm gonna see it. I know that we only have 2 people. We need to get one. Okay, I'm not sure do you have a audio off the lab? Yeah, just how versus. Yeah, but. So, are you guys able to see that? How did he see it?
Yes, I'm here.
Yes, so, Ojo is not, online, so are you okay if we start with you? You get me?
No, what did you say?
I said that the first speaker is not online yet, so is it okay if we start with your presentation?
Okay, okay. Yeah,
Okay.
that's fine.
Okay, great. Well, welcome everyone. My name is Greg Pittman. I'm a professor of history, medical history, and environmental studies at the University of Wisconsin-Madison, and it's a great pleasure to be on the chair this session, Africa in the History of Science and Global Health, which is actually a two-part series that has been organized by Ayudeji Adekite and from the University of Wisconsin-Madison, and Chloe Ayub from the London School of Economics. We're gonna switch the order a little bit. Hopefully, Ojo Afolabi will be joining us.
It's just
Okay, great. So, great. Well, we don't have to switch the order of the presentation. So are you ready to go, Ojo?
Afolabi, are you ready to go?
Can you unmute?
Can you hear us, Ojo?
Yes, I can hear you.
Okay, wonderful. So, well, we're gonna get going, I will not let you go back, so 12 to 15 minutes, not past, at 12 minutes, I'll just give you a sign, you've got 1 minute left, okay? And so our first presenter is Ojo Afolabi from Morgan State University. And the title of his presentation is Weapons of the Weak: Exploring African Agency in Colonial Medical Services in Southwestern Nigeria, 1888 to 1935.
Can you see my screen now? No.
Maybe it's still looking. It's not up yet.
Sorry, I'm having difficulties doing that. Okay, I think I may be having difficulty sharing my screen now, but I probably just have to go ahead with my presentation. I'm Ojo Afolabi from Morgan State University. I'm a PhD student. The title of my presentation, actually, what we have in the schedule wasn't actually what I sent for this panel. It was for another panel, but I think the organizers just sent it to this panel, which is fine. What I still want to present is quite similar to that, which is just a kind of ongoing research. I'm looking at colonial medical service and the contributions of African subordinate staff in southwestern Nigeria, 1889 to 1940. And basically what I want to do with that is to look at the history of colonial medicine in Africa and how it has moved from the triumphalist historiography, especially since the 1970s, owing to the advent of post-colonial writings, for example, the works of Edward Said, Orientalism, with new and more critical and socially inclined views, like the roles of African auxiliaries in the promotion of medicine in Africa. What I'm doing with this paper is to explore the various roles performed by indigenous Nigerian healthcare subordinate workers within the colonial medical establishment in southwestern Nigeria. It has been argued by scholars like Walima that Africans or African medical auxiliaries operated within contradictory episteme, I mean, between Western medicine and African Hindu traditions. And it has also been argued that in some contexts, these subordinate staff approached Western medicine to suit communal interests, which did not necessarily conform to imperial mindset. James Mills has also argued that medical auxiliaries subverted treatment regimes that at times have sympathy for their patients and their rural compatriots, and another time further the interests of their communities. Also, there are other scholars that have argued that African subordinate staff in some institutions have pursued colonial agenda by acting as agents of medical pluralism. However, in taking a close look at the ways that how this African subordinate staff has worked, especially within the colonial medical system, like looking at Nigerian colonial medical service, they have facilitated services that suggest that they actualized other interests in ways that sought to achieve communal interests. Such interest is what Mary Webel occupational contest, in which they operated as colonial intermediaries and local men that acted in ways that enhanced new development and interventions for local health expansion. So basically what my work tries to do is to place these African subordinate medical workers, such as sanitary inspectors, vaccinators, dispensary workers within the colonial medical structure, is to look at how they contributed to the development of medicine. And I'm doing this using the subaltern approach to actually look at the voices of these often marginalized or oppressed groups of African medical workers. Of course, most times been overlooked. If you look at archival sources that are available on the development of health in southwestern Nigeria, you will see that most of the times some of these African subordinate workers, their names are not even mentioned. Some of them they rarely see a full description of their contributions to medicine, in where they actually acted as medical workers. But the truth is that if we look at the colonial medical system, for example, the sanitation regimes in southwestern Nigeria, you'll see that what the African subordinate workers did was far even more than what the other European medical staff did. This is to show that because in terms of population, in terms of availability, these people were more active than others. And that's one of the reasons why it is important to look at the contributions of subordinate African workers. The subaltern paradigm that I'll be using in this paper is critical in terms of how I intend to use it to examine the experiences of some of these often excluded medical professionals within the colonial medical service in southwestern Nigeria. It is important to know that sometimes the subordinate workers were nameless. This is because a name naturally should represent the person, which also provides a sense of recognition or a voice. However, in the case of most subordinate workers in southwestern Nigeria, the colonial power structure relegated this class of medical workers to the background, where most times the identity is mostly unknown. The most influential and high-ranking position remain in the control of the European medical officers. And this, for many years, happened. The African medical assistants, continue to remain in the receiving end of orders. Describing the assistant in the, and now I want to read from one of the archival source that I had, describing the assistant in the first medical ordinance in 1899, popularly known as the Hospital and Dispense Ordinance. An attendant include every officer not being the colonial surgeon, an assistant colonial surgeon, and every clerk, pupil, apprentice, and servant attached or employed at a hospital or dispensary. The reason I read that was that the record itself actually showed that many of these African subordinate workers, many of them were just described as assistants, especially during the early years of colonialism. And this helps us to see why many of them were not recognized. I've used this to describe what Gayatri Spivak actually described as can the subaltern speak, which claims that scholars must speak for the subaltern, because if they could, then they would no longer be a subaltern. But a close look at archival records, which I said, and oral sources, provides that African indigenous subordinate medical workers, such as sanitary workers that I've been saying, dispensary workers, vaccinators, and a number of them made important contributions to medical campaigns, availability during disease outbreaks, and most of the time they were the only available options in the rural communities. And they made significant contributions to medicine and healthcare services in southwestern Nigeria, especially in the rural communities. So in the first 2 decades of the 20th century, colonial states focused on campaigns to combat epidemics and infectious diseases, especially in the tropical environments. Most of the curative measures were left to missionaries. And although it is important to know that the first formal medical campaign in southwestern Nigeria began in the late 1800s, when the British colonial government began to introduce modern Western medicine. This campaign sought to educate Africans about the benefits of modern medicine and to encourage them to seek medical care from qualified practitioners. The campaigns were often faced with challenges ranging from distrust of many Africans about Western medicine. In many other instances, they were largely successful, and by the early 1900s, there was a growing acceptance of Western medicine among African communities. The first attempt to ensure coordinated medical service began in 1862 when Mr. Henry Stanhope Freeman, the governor and the commander-in-chief of the settlement of Lagos, appointed Dr. Hughes as colonial surgeon in 1863. This service was basically for a small band of government officials and European commercial agents. European aid in the areas were perceived as an unfavorable warm climate. And the priority of the British in these tropical colonies and elsewhere, such as India and Kenya, was to actually provide for the European health against, the African health needs. So there were several efforts of promoting development of healthcare services in southwestern Nigeria, starting in Lagos and its close communities such as Badagry, Lekki, Epe, Palma, and in the coastline. This was primarily because the township was populated by Europeans such as soldiers, colonial officials, missionaries, and traders. The first colonial hospital established in 1893 was basically for the service of the Europeans. Other neighboring towns had the services of dispensaries, which were visited occasionally by the medical officers of health. Lagos became a channel through which the British penetrated most of the interior areas. Far interior includes the communities in the present day Ogun, Oyo, Ondo, Osun, and Ekiti State in the interior areas. Modern medical legislation started in 1880 when Lagos was growing as a commercial emporium. It became necessary to expand the administration of the colonial hospital, which was catering for the Europeans. Hence, the Lagos Hospital Ordinance was passed in 1899. This ordinance ensured the expansion and the regulation of medical services in Lagos. So by 1889, a more comprehensive legislation was passed, known as the Hospital and Dispensary Ordinance, which provided for the appointment of a colonial surgeon who was charged with the control of hospitals and dispensaries in the colony. One major development that followed the passing of the ordinance, and the reason why I made reference to that was that it helps the expansion of medical and healthcare services in Lagos. Prior to 1887, the Lagos Medical Services was completely manned by expatriate surgeons. African medical officers were, as a matter of policy, barred from the appointment of as colonial surgeons. For example, in 1884, the application of Dr. J. Jenkins, native medical officer, for appointment as assistant colonial surgeon was declined for reasons of racial prejudice. These circumstances and the exclusion of Africans from the colonial medical service soon became a matter of agitation in the upsurge of racial circumstances which arose in the 1880s. And this—
Excuse me, I'm sorry, you're gonna have to wrap it up. You're at time.
Yes, what I'm actually trying to get to really is to help us see that from the early years of colonialism in southwestern Nigeria, Africans were seen as assistants. They were seen in the background. They operated within the colonial medical structures as just attendants. But then their contributions to medicine cannot just simply understood, because many of them worked beyond decades of the colonial authorities and did a lot of things to suit their own communal interest. So basically, looking at African subordinate staff in the history of colonial medicine in southwestern Nigeria is very, very important. So this is just the basics of my presentation. If you have suggestions or questions, I'm open to attend to them. Thank you.
Great, thank you. We'll hold questions till the end for everyone. And our next speaker is sorry. Our next speaker is Adisi Lade. And the title of his talk, as you can see, is Colonial Sanitary Technology and African Resistance, Raising the Politics of Food Management and Public Health in Lagos, 1900 to 1920. Thank you so much.
Thank you very much. Can you all hear me?
Yes, sir.
Okay, so I'm going to be talking. So before I start presenting my work, I want to appreciate the conference as well as panel organizers for making this possible. So today I'll be talking briefly about my research titled Colonial Sanitary Technology and African Resistance. What I'm going to be talking about is I will rethink the politics of sewage management, poop management, and public health in Lagos between 1900 and 1920. So basically, the paper talks about, the paper looks at the early efforts made by the British colonial government in Lagos to manage feces as a way of improving public health. Before 1900, the method that was used by most Africans in Lagos to manage their feces was basically open defecation. People discharged their feces uh, either in nearby bushes or in the lagoon or on dump sites in their area. So basically, most people practiced open defecation, but in some places, Africans used land-based technology which was generally known as pit latrine during this period. So this pit latrine was dug at the back of their compounds to manage their feces. Despite the varied system, those that practice open defecation on dump sites or those that defecated in their compounds in the pit latrine, most Africans saw dump sites during this period as their public toilet. But under colonial rule, things change a little bit, as many scholars have argued, especially Ayodeji Olukoju and many other scholars that have written on Lagos, argue that the European tried to transform the Crown Colony into what they call the Liverpool of West Africa. In this regard, the British colonial government, in the first decade of the 20th century, they embarked on a mission to sanitize Lagos. And in order to advance this aspect of their civilizing mission in Nigeria, the colonial government initiated modernizing public health programs that included human waste management. So my research today will be talking briefly about some of the efforts to implement radical hygiene programs, which included imposing on African public the use of imported latrine buckets. And in exploring these politics that accompanied the introduction of the sanitary technology, my paper attempts to answer two important questions. So the first question is about, I wanted to know how Lagosians perceived and responded to the British initiatives that aimed at reforming human waste management in the early 20th century. And the second question that I try to explore in my paper is that what were the implications of introducing and imposing new poop technologies on colonized Africans, and how did the sanitation program sort of impact public health in the rapidly urbanizing town before 1920. So my argument in this paper is divided into two. So the two significant factors that shifted, that stifled early Anglo-Yoruba attempts to improve human waste management in colonial Lagos were this. Number one, I argue that the paternalistic attitude and intervention of the British colonial government, which sort of sought to sanitize Lagos and the local population by reforming their perceived unhygienic practices, offended many Africans. Many Africans detested the European colonizers for imposing a new set of costly hygiene practices and technologies on them. The second argument is that the subaltern politics, which some Africans played in order to counter the British sanitary enlightenment, which imposed new, alien, and costly changes on them during this period, restricted attempts to sort of improve public waste management and sanitation in the rapidly urbanizing town during this period. In other words, Lagosians cared less about any positive impact the hygiene program by the colonial government could have on them or the public due to the high cost of the initiatives at the time when they were asked to pay other bills like water rates. Yeah, so I want to quickly talk about some of the technologies used during this period as a way of managing sewage in Lagos. One of the early public hygiene intervention by the British colonial government uh, was not really new in Lagos in the first decade of the 1900s because some Africans had been using it before. This was a pit latrine, as you can see from the slide. Although that was not the original pit latrine that was used as public toilets in the early 1900s, but that was just to signify, what it looked like. So, in order to reduce the cases of open defecation in the colonial capital city, the colonial government sort of built more public latrine in some districts. Although some Africanist scholars have argued that colonial government did not provide sufficient sanitary technologies like public toilets in urban centers in Nigeria. In fact, some scholars sort of described the provision of this hygiene infrastructure as evidence of racial discrimination, since they were not, similar to what was used in London, which was water closets. But my archival sources reveal that colonized Africans themselves considered the land-based technology that Europeans sort of try to, increase in urban centers as what they call intolerable nuisance in the early 1900s. But yet, the colonial authorities deemed the Shalanga system, which was called in Lagos back then, the Shalanga system to be appropriate for Lagos due to two reasons. The first one was the lack of, public piped water system in Lagos. And the second reason the Europeans tried to increase the pit latrine was because of its cost effectiveness. What do I mean by this? During this period, it was impossible for the colonial government to introduce water closet in Lagos because there was no waterborne system that could be used, in transporting the waste into a central sewage system. And then to even build that at that period would cost a lot of money that the Europeans were not ready to, expend on their colony. And which ties to my second point, which was the cost effectiveness of the pit latrine system. Since colonialism was not about humanitarianism, the Europeans were not willing or ready to spend so much money on providing Africans with improved system for sanitary development during this period. So they simply provided more public pit latrine for people. The features of this latrine included the fact that they had no seats. And then the sort of cover that was used during that period were not tightly, so it created favorable environment for disease spreading flies. But more importantly, because of the limited funding available for the colonial government to manage the colony, they provided very little funding for the maintenance of these facilities. So although many sources have argued and blamed the colonial government, like I said, for providing very few resources as well as facilities for Africans, I am arguing here that during this period, sources show that urbanized Africans themselves during that time did not actually want this pit latrine, because to them, the nauseating odor coming out from this pit latrine to them was not acceptable. So many Africans did not want these public toilets around their districts. So this sort of negates the argument of some scholars that the European government did not make efforts to provide Africans with sanitary technology. So from this slide, you can see examples of the sanitary technology that I'm talking about. The reason why I'm providing two different images is because archival sources do not reveal, the exact technology inside those buildings, but the buildings were actually located in Lagos. So the technology provided after the outcry of Africans became too loud was what they call fly-proof technology, which you can see on my right screen. This fly-proof technology was to sort of address some concerns of Africans during this period, which included, the creation of environment favorable to disease-carrying flies that, the pit latrine toilet aided during this period. But despite the fact that the colonial government provided this fly-proof technology to sort of replace the pit latrine, Africans were still not satisfied with the efforts made by the colonial state. And some of the arguments was that the nauseating odor coming from this pit latrine was not healthy for them. And as a result of that, many Africans argued that the colonial state should remove most of these toilets away from their district away to nearby water bodies in order to aid the cleaning process. However, this idea was not acceptable to the colonial government because it sort of negated the idea of reducing open defecation. The colonial government believed that if Africans had to, travel a long journey from their home to nearby water bodies to defecate, sometimes at night it would not be possible for them, and that would mean defecating openly in, their area. So as a result of this, the colonial government did not remove some of these public toilets. But the other part is that at some point, the colonial government tried as much as possible to introduce what they called a tram, sanitary tram, which was to transport sewage from the urban areas away to the nearby town where it was disposed of. So after the introduction of this particular tramway, the colonial government also responded to the call for the removal of some of these public latrine. But the latrines were not entirely removed. What the colonial government did was to sort of introduce a new technology, which they called odor-proof technology. This odor-proof technology, I tried as much as possible to sort of locate an image of, to find the image in the archives, but I could not find the image. So the idea was that the odor-proof technology will be imported from Europe, and then they will be used both at home and in the public. But there were a lot of difficulties with this technology, and some of the difficulties that were encountered during this period are what you can see from my slide. The first one was the fact that since the sanitary tramway that was introduced in 1907 was mostly serving areas that were lived by European officials and rich African natives, during this period they did not impose the technology on everyone. So rather than that, they first piloted it in the middle class and European area. And in these areas where it was piloted, there was little resistance to the cost of acquiring it or the use of the new pocket latrine. But when it was finally introduced to everyone, the colonial government mandated that Africans had to obtain the technology. And some of the problems that was encountered was the fact that it was difficult for Africans to empty their pocket latrine at the time that the colonial government mandated them to empty it. Initially, the timing was that Africans were to empty their pocket latrine from 9 p.m. to 11 p.m. But many Africans complained about the nauseating smell that many people empty their latrine, their pocket latrine at that hour of the night always had. Some complained that it was during the time they were returning from work, and then the nauseating odor was too much for them. They could not bear it. So the colonial government tried as much as possible to change the hours. They changed it from 9 to 11. They changed it to 11 p.m. to 4 a.m., allowing many Africans to, get home late, and then they can start emptying their pocket latrine. But still, this did not work for other reasons. Some of these reasons was the fact that many Africans found it difficult to comply with the cleaning rules and regulation. As you can see from my slide, some of the articles from the newspaper that I researched, it shows that many Africans would not agree to empty their pocket latrine at the appropriate places designated for the waste. Rather, many Africans just empty their pocket latrine in places where the waste constituted public health threat. According to the editor of the Lagos Standard newspaper, prisoners that were employed, hired, or recruited to empty public toilets, they mostly throw the waste in places that constitute a public health threat during this period. While the timing indeed may not have worked for many Africans in Lagos, sources also show that they did not abide by the specific hours for cleaning the pocket. Simply because they did not actually want to make the programs work. And my argument is that during this period, they felt that they did not want to make it work so that the colonial government would not feel welcomed in Lagos or feel like appreciated for his initiative. But the most divisive issue about the public latrine or the bucket latrine that was introduced during this period was the economic part, the cost aspect of it. So the British government tried to rip off many Africans by imposing the technology on the local population. Apart from leasing the technology to Africans at a rate of 6 pence per month, Africans were also required to pay the 6 pence for 4 months in advance before they could receive the bucket. And this made many anti-colonialists, including the white cap chiefs in Lagos, to quickly condemn the initiatives, describing the waste management program as a monstrous piece of business, which was designed to rip off many Africans. Many poor, low-class, and struggling Africans in Lagos also opposed the compulsory acquisition of the latrine pockets because the colonial government did not permit the use of local alternatives. Many Africans argued that pocket is something that they could easily get locally, but the colonial government insisted that the imported bucket was odor-proof and it was what was approved for emptying their waste during this period. But the worst case was the scarcity of the same bucket. Oh, okay, yeah. So I'm almost through. So what provoked many Africans more about the British poop business, as I call it in my paper, was the scarcity of this government-approved latrine bucket. Because at the time that colonial government was mandating the acquisition of these buckets, they were not actually available locally for people to purchase. And interestingly, after people have paid for it, the colonial government will now ask people to use the locally sourced buckets and wait for the arrival of the imported bucket. So this felt like a rip-off to many people who continue to protest its use. By the outbreak of the First World War in 1914 up to 1918, the importation of these buckets was, limited because of the war. And as a result of this, it reduced the capacity of the colonial states to further enforce its use. But in conclusion, indeed, many scholars have, explained that the unsanitary practices of some Africans was a simple problem, which they call a systemic failure of the colonial government, which, which was provoked by the colonial government. In other words, they argue that the insanitary attitude or behaviors of many Africans in Lagos was as a result of the systemic failure of the colonial government. But in my paper, my argument is that even though this was true, sources shows that it was not that simple. In addition to the colonial government neglect of poverty among the colonized people, as well as the poor salary that was paid to sanitary cleaning, the sanitary laborers that was cleaning the public toilet, I argue in my paper that the uncooperative attitude of many Africans also shaped the government efforts to safely manage sewage in the first 2 decades of the 1900. And this ends my presentation. So if there are questions on the sanitary technology, I welcome them, and I would like to have further discussion about the sources that I've used in the paper. So thank you.
Next speaker is 15am-10 from the University of Michigan. And the title of her presentation, Results of Ethnicity, Politics, Religion, and Cultural Practices in Vaccination in China.
Good morning, everyone. Can you hear me? Thank you. So I will be presenting on the roles of ethnicity, politics, religion, social strata, and cultural practices facilitating vaccination in Nigeria. First, before I start, I would say I know everyone knows what vaccination is, and I believe that most of us actually do vaccination to get to this stage we are. So here, I will be doing a general overview, even though my work is still under progress and I haven't got a historical background from some extent my work. So I will be doing a general overview of vaccinations and some infectious diseases they are treated in Nigeria. Okay, so first I would be saying defining what vaccination is. Vaccination, in a simple term, I would say is the use of needle and syringe to inject drugs or medicine which are inserted as drops through the mouth to prevent certain infectious diseases. However, the concept of vaccination is not strange to Africans, especially Nigerians. The general assumption is that ethnicity may have hindered Western biomedicine reception in specific geographical settings and locations in Nigeria because it is a pretext for colonial control. Suspicion, however, does not indicate that various ethnic groups in Nigeria were viewers of vaccination knowledge for colonization and the wholesale circulation of Western biomedicine. However, among the Yorubas, for example, there is the widespread of the practice of agestera, which means that what is eaten and retained in the body serves as a healing protocol for preventing diseases and managing diseases in southwestern Nigeria. Also, vaccination is a process of injecting antibiotics to the body to prevent diseases and pandemics just Nigerians. Different cultural and medical practices, although the intersection of Western and indigenous paradigms of vaccination knowledge have not been studied to the extent that scholars would refuse how indigenous medical practices has helped to boost the understanding of Western vaccination. By transferring their knowledge of herbal remedies and incantational system as vaccination forms, the Yorubas could readily accept vaccination or orthodox medicine, unlike other ethnic groups in Nigeria. Here I'll be looking at factors that militate vaccinations in Nigeria, which includes social strata, ethnic and cultural and religious practices, and some other political policies. These are issues that are militating vaccinations in Nigeria. Talking about the social structures, social structures has always posed the rationale behind the fact and belief that natives, particularly native children, were the primary carriers of vaccine-preventable diseases, since the resources to tackle the disease was minimal among poor villages in Nigeria. However, in most cases, the upper class in Nigeria would feel reluctant to take vaccines, and it can increase the rate of infectious disease spread. The influence of social structure in militating vaccine acceptance in Nigeria includes income, education, and occupation. Higher socio-economic status often correlates with better access to information, healthcare resources, and higher vaccine acceptance rates, while lower socio-economic status can lead to greater vaccine hesitancy and lower acceptance levels due to limited access to accurate information and healthcare services. Ethnicity, religion, and cultural practices militating vaccination in Nigeria. Cultural beliefs and attitudes towards vaccinations are among the factors militating routine vaccination in Nigeria. According to Ademola Adetiba in his article on traditional medicine in the fight against infectious diseases in colonial northern Nigeria, he noted that from time immemorial, northern Nigeria has been ravaged by diseases. However, among the Hausa people, particularly the core northerners, who are not privileged to have informed education and enlightenment, they do not particularly recognize that these diseases are preventable. To the Hausas, they believe that Western drug is a form of control to sterilize. In the case of polio, they believe that Western drugs is a form of control by the colonial masters to sterilize female Muslims in northern Nigeria. Why to the Yorubas? Vaccination has not been an issue because they are used to traditional medicine, which is always known as agbo. However, Ajacera among the Yorubas is referred to being immune by herbal medicine to boost immunity. And to the Igbo, vaccination has always been known as Ogu Mbochi, which means to take in substances to prevent you from being sick, which is being done after thorough examination by some herbalists. Okay. Politics and vaccination. I'll be looking at the political factors that militating vaccinations in Nigeria. Political factors that are militating vaccination in Nigeria could come as policies that the government puts in place. Most times, it might not really favor the people, or most times, whenever these policies are being taken place, sometimes there are regions who would not accept such regulations from the government, especially when it comes to, oh, you have to immunize your child at so age. While to some traditional people, they would not want to undergo that, especially for those who don't have this enlightenment that vaccination for children less than 5 years old are free. Political factors can have significant impact on vaccinations efforts in Nigeria. Here are some of the political factors. Government policies and priorities. The policies and priorities set by Nigerian government plays a crucial role in determining the focus and resources allocated to vaccination programs. However, if the government prioritizes healthcare and vaccine distribution, it can result to better access to vaccine and higher vaccination rates. This is because in some cases, the distribution of vaccines in Nigeria, especially towards the northern part of Nigeria, is lower compared to southwestern and southeastern Nigeria. Vaccine distribution in the northern part of Nigeria, I would say the distribution isn't so much, maybe because of the Muslim belief that, we don't need some of these drugs, or okay, sometimes you don't have to see our girls, and so when policies are being taken for vaccine distributions, so in some part of the country, which is the corner, some of them are not allowed to take this vaccine. So these are some of the political issues militating vaccine in Nigeria. Okay, secondly, I'm talking of funding and resource allocation. Political factors that influence the allocation of financial resources and infrastructure for vaccination programs. Sufficient funding is required to procure vaccines, establish vaccination centers, train healthcare workers, and carry out public awareness campaigns. If the government prioritizes vaccination and allocates adequate resources, it can enhance the vaccination process. However, if there is a lack of funding or mismanagement of resources, it can impede vaccine distribution and administration. In this funding and resource allocation, in some part of Nigeria, as we all know, some areas have funding, whereas some areas don't have funding. And when this is being done, when fundings are being released, some health workers will prioritize to go to areas where they know that, oh, I will get paid well for undergoing vaccine within children, compared to some area where you feel like, oh, I wouldn't be paid well if I actually go and take vaccines for children over there. Okay, I'll be looking at vaccine hesitancy, which is under the religion beliefs. And under this religion belief, we have the Muslim religion belief and Christian religion belief, which is among the factors militating vaccine immunization in Nigeria. So vaccine hesitancy, despite the overall support from Islamic leaders, some pockets of vaccine resistance still exist in northern Nigeria. Concerns has been raised by a minority of Muslims who question the religious permissibility of vaccination based on misconceptions or misinformation. Some individuals associate vaccination with conspiracy theories or consider it against their religious belief. Whereas to the Christians, the Christianity is also practiced in northern Nigeria, particularly among minority populations. Christian leaders and organizations have generally supported vaccination, considering it as a means of safeguarding public health and protecting human life. However, during the case of Ebola, among the Christians, there were people who actually believed that bathing with salt, putting salt inside water would prevent you from contacting Ebola in 2014. And this actually caused a whole lot of the spread rate of Ebola then, even though it was minimal in Nigeria, but most Christians actually contacted this Ebola because they believe that, oh, my Christian belief, I would pray about it, I would take salt and drink and all of that. And during this COVID-19 that we concluded, some Christians actually believed that it was just a white disease to prevent church gathering and worshiping God. So these are the Christian belief that when you tell them to go take vaccine against some infectious diseases, they would be reluctant to do this. So the Christians often highlight biblical principle of loving your neighbor and the responsibility to care for one's health and well-being of others. This is because in some cases of infectious disease, you see Christians saying, oh, I can't leave this person, and let me keep taking care of this person. Whereas the person who is attending to the patient doesn't have vaccine either. So instead of going to take the vaccine, the person would choose to, back it up with this biblical allusion that I can't contact the disease because I am taking care of a sick patient. Okay, I will be concluding with strategies to help address challenges of ethnicity, politics, social strata, which is militating vaccination, which is through education and awareness campaign, engagement with community leaders and religious institutions, strengthening health care infrastructure. I think this is the most important. In some places in Nigeria, healthcare facilities are really, really low. When I visited the Oju leprosy settlement, I could tell you that this particular settlement, that all the houses were depleted. In fact, there was nothing there anymore, but we still had leprosy patients still living there. So you see that healthcare workers over there don't even pay attention to these people. So the government should be able to strengthen healthcare infrastructures in Nigeria and also collaborating with international organizations, the World Health Organization, and to also engage in other policies that is being implemented to be able to reduce infectious disease spread through vaccination. Thank you.
Thanks so much. So is Muhammad here?
I have a notion.
Huh?
I have a notion, so he probably doesn't like me.
Okay. So we're going to then turn to our last speaker by Patrick Opalaki and James Ika on the exclusion of all exciting stimuli and the hypnosis of talk, knowledge production, and decolonized insights on indigenous mental health care.
Yeah, thank you. Good morning, everyone. So basically, I'm going to be speaking on some of the findings about an ongoing research. More or less, is a research in progress, about 50, 60, 70% completion rate. So given the theme of the conference, which has to do with decolonization, we started to think what we can actually do with regards to decolonizing knowledge on mental health care or psychiatric in colonial Nigeria. And I wish you could bring that in. Okay, so and then we actually realized that based on colonial archival documents, correspondence between colonial officials, there are certain silent voices that have not really been, put into the conversation when we talk about mental health care in colonial Nigeria, particularly from the 1930s to late colonialism period. Basically, there's an epigraph that actually formed the rationale for the research, and that has to do with a report by a senior district officer who actually served in the then Ikot-Ekpene district before being transferred to the Bamanda areas in then southwestern Cameroon. And it has to do with him receiving a complaint from an indigenous inhabitant of Ikot-Ekpene area, who actually reported about the wife being held up by what we then known as the native doctors, who were the specialists in terms of mental health treatment. Permit me to just do a very quick reading to help shape the presentation. About 12 miles north of Ikot-Ekpene lives an old native doctor, witch doctor, as the missionaries called him. His success in treating madness was widely known in the area. One day, a man complained that the doctor had deprived him of his wife and was keeping her tied up. I went out to see what was the matter. Sure enough, there was a woman confined in a darkened room, whom the complainant alleged was his wife. I asked old Abasi, which is now the native doctor, for his story, and he said, the father of this woman brought her to me to cure her madness, and I am doing so. I asked him his methods, and he said he had shaved the woman's head, had put cooling plasters on it, was keeping her in a darkened room and quiet away from people, gave her plenty of water to drink and cooling food, and went often and talked to her. I left her with him, and 3 weeks later, I heard that she was completely cured. His method were sound, quiet, darkened room, light diet, and the exclusion of all exciting stimuli and the hypnosis of talk, or as it is referred to, the psychoanalysis. Now, this is the rationale. It's an epigraph from a senior district officer. What we are trying to situate within the ongoing debate on colonial mental health historiography is there are certain reports from colonial officials, not the indigenous population, that are yet to make it into the literature on psychiatric history in colonial Nigeria. It simply shows that there were colonial officials who actually had first-hand experience of how traditional form of mental health treatment played out very efficiently. However, we could not really ascertain if these things were suppressed because of, at that time, Western biomedicine was also making its way and was also being expanded vigorously in the area. Now, the research is focused on southeastern Nigeria, and we are not only looking at the Ikot-Ekpene area. We've been able to scout the archives in Enugu and Calabar that shows even in the Onitsha province that had about 12 divisions, the Ogo division, the Enugu division, Oka division, Onitsha division, the rest of them. There are ample cases of reports from colonial officers as well in areas like district officers of Udi, for instance, Captain Elimi, the Unsuka district officer, Captain PM Ryland, the Oka district officer, Mr. PV Mine, among others, further testified to having experienced these indigenous methods, approaches, and insights towards treatment of mental health disorder within the period of 1900 and 1940. But then here is the gist. There is a sort of rich and expanding literature on mental health care in Nigeria. And our research seeks to find a place to fit in. So the narrative will be that in the global context of science, in the global context of medicine, in terms of healthcare, there were actually certain reports that could have actually, shaped the argument or how mental health treatments were to be perceived or probably were to be understood. Unfortunately, not much literature have given consign to some of these indigenous knowledge systems that were used and also reported and could have been adapted in the global literature on, especially in terms of Western biomedicine, like, psychoanalysis. And it is interesting to also note that we also discovered that by 1939, when the execution of what was called the African Survey had started, it was a sort of idea that was proposed by General Smoot in an Oxford memorial lecture in 1928, where he was talking about the need for the British colonial government to reinvade Africa and other colonies and take time to understand the indigenous life of the people, to understand it in the sense that earlier reports were documented in haste. So the African Survey, we realized that, for instance, in the context of medical or generally medical history or medical practices, right? Traditional medical practices, or specifically on mental health care, earlier reports that negated the practices of Africans were later, reconsidered. Now, I'll give you an instance. Prior to the 1930s, majority of those traditional healers were, variously dismissed as witch doctors. It was in the context of the African Survey that was carried out from 1939 that they came to realize that there was a need to know that there was a difference between witch doctors and native doctors. Yeah. And even inside the practice of native doctor or native medicine, there were various specialties. Just like in the case of Ikodabasi, we have also seen evidence about close to 45 reports which talked about mental health practices, not from the Western biomedical perspective, but from that of the indigenous knowledge system, where they were reported not by indigenous people or the population, but by colonial officers themselves. Now, it's interesting to know that at that point in time, we have seen that what is good or fit to be termed as, medical methodology was shaped by the West, as Megan Vaughan have actually posited in her book, and also Matthew Hilton and the rest of them who have taken time to discuss some of these issues. But then the argument we are trying to make is we are trying to situate or probably recalibrate the way we approach issues of mental health, and to also see that Africans also contributed to the treatment, the methodology, and ideas on mental health discourse in the global context. I think we've been able to structure our work to have various sections or segments, and one has to do with disease of the head, crisscrossing biological, socio-psycho, and supernatural realm. In the traditional form, for instance, you can't cure what you don't understand. Just like in the Western medical field, you have to look at it from the neuroses or the psychosis. But in the traditional realm, you have to understand if what the person is going through is biological, psychosocial, or supernatural. Odabasi in Nikodem actually told the colonial officer that, look, I don't treat all kinds of mental issues. I will first understand if the person has been caused by ECMO. ECMO is one of the masquerade institutions they had in the area I'm discussing right now. So we are looking at that. We're also understanding how the African Survey influenced these reports by colonial officers across southeastern Nigeria. And we're also trying to decolonize mental health care using subaltern reports in southeastern Nigeria that have not been captured fully in the rich and thriving, expansive literature as it is today. So I think that is what we have done so far, and I really would like to stop here for now. I expect comments, feedbacks, ideas, and suggestions that will help you the work. Thank you very much for listening.
Okay, what you just said,
I would have loved that epigraph, but it's fine.
Because of the no-show and a need for space for another person who's joined, it's part of LSA. We're adding another paper it's Nathaniel Omoloni. Yeah. And I'm sorry, I don't have the title of your paper.
Identification,
Speak up.
identification of indigenous thoughts parallel to the learning theory of the epistemological knots. Identification of science education.
Good morning.
I'm presenting a topic titled Identifying Indigenous Thoughts Parallel to Learning Theory of the Epistemological Knots. Education for Science Teaching. Basically, there have been research on the scientific thoughts that are indigenous before contact was made with the colonial masters. And almost all the science concepts have one particular indigenous explanation in form of proverbs, in form of incantatory poetry, in form of adage. For instance, the factors that affect growth known to literature in biology, one of them is nutrition, another one is the gene. So the size of anyone is, the growth of anyone accounts for these two factors. And within the Yoruba proverb, there is a proverb that says, I jẹun ológìnní ni ò jẹ́ kó tó ajá, kọ́ ni ò jẹ́ kó tó ajá, bí wọ́n ti ń mọ níran wọn nìyẹn. The meaning of this proverb is that the domestic cat in the Yoruba land is actually smaller than the domestic dog, not because of feeding, but because in its lineage, the way they call it, that is their size. So within the indigenous thoughts, there are scientific concepts that are explained. For instance, if we talk about escape velocity, there is an incantatory poetry that says, if we talk about rate of chemical reaction, there is an incantatory poetry that says, kankan loro na mugi. All these explanations are existing, and there have been advocacy for making sure that this explanation improves the teaching of science. However, the process of teaching science and teaching generally is informed by learning theories. And these learning theories inform science teaching as well as everything done in the science classroom. For instance, we have during the pre-service teacher training, the teachers are exposed to learning theory that usually informs whatever they teach. But it is good to note that all this theory, they are not theories that are proposed by the scholars. They are proposed by scholars from the epistemological north. That means when we are preparing the science teacher, the theories of learning that we use to prepare the science teacher is not the theories proposed by, does not have the coloration of the indigenous knowledge. And one proverb says, "Oni adinitin shegbeyawo, alamu shenawo, labalaba lohun ojo ajofaya, she ìran wọn máa fàyàwọ́lẹ̀ ni." The meaning is that there are two families of reptiles that are actually having a celebration, but a butterfly, which is an arthropod, wants to attend and dance. Is not part of it. So the learning theory of the epistemological north, often they use the children and observation of the epistemological north to propose the theory. But there are evidence that there is actually a cultural gap and a border that the learning of science must cross. And this must also inform the teaching of those theories to the science teachers. Now, for instance, the constructivist theory of learning for science teaching proposes that any teaching of science concepts must involve the use of instructional material such that the learner must be exposed to concrete experiences in the science laboratory so as to learn and deepen learning. And it is very important to know that this theory of learning are products of observations of social interaction that are associated with learning. So this morning, I just came to profile and identify some indigenous thoughts that are parallel to some of the learning theories that we have. Because our proverbs are oral forms of literature. And some of these proverbs usually document social interactions that are product of observation of human behavior and environment. Similarly, the theories of learning are also products of observations of the social interaction that are associated with learning. For instance, the constructivist theory. The constructivist theory says that whenever you want to teach a child anything, you have to provide him with concrete material, and that informs the use of instructional material. And one of our proverbs, it says, "Ọmọdé kò mọ òwe lówe, ọmọdé tí ò mọ òwe lówe, à mú òwe sọ́tún, à mú òwe sósì, à fi hàn." The meaning is that if a child cannot differentiate between owe and owe, there are two legumes. Owe is a legume, owe is also a legume. If a child cannot differentiate between owe and owe, the only instructional approach is to bring owe out and show him, and also show the child owe. So if the constructivist theory of the epistemological north insists on deepening learning experience in science teaching through the use of instructional material, we equally have a parallel in our indigenous thoughts that is emphasizing the use of instructional material. Another theory, the constructivist theory also indicates that whenever you want to teach a child, the objective of learning should inform the choice of the instructional material that the child will use. For example, whenever I want to teach a child how to fold filter paper, I will only demonstrate. But whenever I want him to use the filter paper to actually filter material, I would have to make him participate. And we also have an indigenous thought. Only he said, Oju la mo beti o lepo, itowo la mo iti o niyo. It means that for a child to experience a soup in its details, it's very important that the child taste it. The viewing experience will give a limited understanding of what the soup is all about. So the implications of these thoughts is that even for the behaviorist theory, they will say that that means our behavior is actually informed by external and internal stimulus. That means whenever a child puts his hand inside a place where there is something that can bite, a scorpion, his hand must not stay long inside it. It is that stimulus that is controlling the behavior. So there are numerous indigenous thoughts that are actually parallel to the behaviorist theory, to the constructivist theory, which can be used in the process of science teaching. Now, what is the implication of these thoughts? The implication is that in the process of teaching the science teacher, in many studies, I have actually profiled many of the proverbs and concrete materials that can be used in the indigenous way to actually teach science. But this teacher that is also teaching, while we are preparing the teacher, we must not just present to them the epistemological not learning theories. We must find a way to integrate parallels, indigenous thoughts that is informing how science should be taught. Thank you very much.
So thank you, everyone. We have about 10 minutes for questions and discussion. I just briefly just want to say how wonderful and refreshing it is to see. I was saying to Ayo the other day, this kind of Nigerian wave of young medical historians emerging. I think it will really help shape scholarship and the global dialogue around the history of medicine and public health in Africa. We see a number, I think, themes that have come out in all these presentations that have been currents, within in medical history. Questions around agency, questions around medical pluralism, questions around the archive and who is silenced in that. I think in all the presentations we see, to paraphrase from German physician Rudolf Virchow from the 19th century, that medicine is politics by other means. Both in terms of its colonial imposition of Western ideas and practices, but also in African resistance and adaptation. And I think that one sees in all of these presentations that the kinds of medical practice, public health interventions, and so forth have never been a one-way street, and that a system emerges in this context in Nigeria that comes from a interaction and contestations between British colonial officials and Africans in that relationship. I have a number of thoughts about each of these papers, but I want to really open it up to the floor for discussion. So and questions. So please. And could you introduce yourself as well?
Okay.
Please.
My name is Damdola. So my question is related to. Can you hear me?
Sorry.
The mic on.
I think it's not volume. Is this thing on?
Yeah.
It is okay.
Okay, thank you. All right, good morning, everyone. My name is Damilola Fagite, and I'm directing my question to Dr. Alade. First, I would like to thank you for that beautiful presentation. So my question is that, can you share more insights on how the colonial governments were able to address the difficulties posed by Africans in the new colonial sanitary technology? So I would like you to share more insight on that. And then, did the colonial authorities actually put in place any measure? And then if yes, can you give an insight to that? Thank you.
Thank you very much. Can I go ahead and respond?
Dr. Alade, maybe you hold on because I also have a contribution and a question for you too.
Oh, okay.
Anyway, then there's another question for you, so let's follow them in the interest of time.
Okay. Good morning, everyone. My name is Temitayo Omigule from Obafemi Awolowo University, Ile-Ife, Nigeria. Dr. Alade, I enjoyed your presentation, and I must give it to you, just I'll give it to other presenters that you all did well, and it was a beautiful presentation. I want to first suggest that I would like to work with you on some certain areas of your research, which I feel that we could both look at it as a collaborative research. A counseling psychologist in education, and I would like us to look at career choices, job hazard, and poor management in Lagos within the year frame with which you have worked. I will email you for that. Then my question now is that, looking at I knew that towards the early years of my childhood, I could remember there were some workers that does this job. We refer to them in Lagos State then as Agbepo. Are you aware of that there are some career choices that some people chose to perform that happens that situates their career in poor management? And in the Yoruba setting here in Southwestern Nigeria, precisely Lagos, we refer to them as Agbepo. I feel strongly that in your own research, maybe the conceptual framework, you could include the idea of career choices that has to do with the Agbepos into the framework. That is my suggestion for you. Then please, can I go to the next person now? For Ifeoma Anike, am I right? You did well, your presentation was okay, but you missed a lot of terminologies and all of that. I would like that you revisit all of your work, check through the terminologies. When you were saying Ajesara, for like the first few minutes you were talking, I thought you were saying Al Jazeera. Until I processed it and I tried to, so it is Ajesara. That is something you take into your body, Ajesara. So you could ask a Yoruba person to give you the tone marks, so it will help you in future presentations. So check your terminologies again. Then, sorry, please. Mr. James, am I right?
Yeah.
Patrick, thank you so much. Your presentation examining the mental health and all of that, it's beautiful. I want you to look at the difference between witch doctors and native doctors. Are there really major differences between witch doctors and native doctors? Because if you look at the way, particularly in Nigeria, when they say somebody is a witch doctor, automatically they believe it is a native doctor. But in your presentation, you made mention that there is a difference between witch doctor and native doctor. So I would like to ask you, can you just give us an insight into what that difference is? So that's the question for you. Then finally, sorry, sir, Ade Tokumbo Oluwole, am I right? You spoke about the colonization of medicine in West Africa. Am I right, please? Is it not here? Is that Tokumbo here? No, okay. Then who presented on the parables, proverbs of Yoruba? Okay.
Time.
Okay.
Someone else. Who is the next person?
I will see you in
Who is
person.
the
and
next?
give it to you.
Okay. Is the charger right? Yeah. Are you the only one here? So. Let's say.
So, Dr. Alade, you want to go first? Not sure.
Yeah. Okay, speak to it.
Okay, yeah, thank you very much. So these are insightful contributions from the audience, and I really appreciate the questions regarding the responses of, colonial responses to African complaints, as well as the suggestion about career choices. Actually, let me start from the career choices. So in the full paper that I'm researching on, I actually look at these career choices, although it wasn't really the focus of the paper. But because I was discussing the various efforts by the colonial states to ensure regular cleaning of the public toilets, I had to also include the perspective of some of the sanitary laborers that were hired. And in the paper, I actually discussed it at length. And when the paper is published, definitely I'll be glad to share it with the LSA community. But definitely, I also welcome your perspectives and look forward to collaborating with you on, on this kind of project. To talk about the responses, questions on the responses of colonial government. So you see from my presentation that I mentioned right from the late 19th century to, 1910, there were attempts by the colonial states to respond to some of the demands of Africans. For instance, many Africans believe that public latrines should not be situated within their community, within residential area, because of the, nauseous and nauseating odor coming from those public toilets. One of the responses of the colonial government to this was to, change the system from pit latrine to the introduction of bucket latrine. With the bucket latrine, they believe that can be emptied every night. But the problem with it was that it did not comply with the demands of Africans, whether it was bucket or it was pit. Africans did not want it situated within their community. So the problem that I identify with that in my research is that the colonial state did not include Africans in the decision-making process. And it was not just the case of public health. It was, it cut across the whole colonial, era from 1900 to the independent period. So, and the same problem also played out even when they introduced the odor-proof bucket latrine. The idea was to, empty it from between 9 p.m. and 11 p.m. But this time was not dictated by Africans. The Europeans dictated the time, and it did not work for Africans. And, where the case sort of shows to be a nuanced one was when they also extended the time from 11 p.m. to 4 a.m. Even that did not work for Africans, which is where I had to point to the politics of public health that Africans themselves were also playing with the colonial state. But to say that the Europeans or the colonial government did not respond to some of the demands, of course they did. But these responses did not align with the interest of Africans. And the reason why it was not aligned, yeah.
Sorry, we are out of time, please.
Okay.
So we have another section, the continuation of this section, that we can take the rest of the question, and if we are snapping with time, we can address the rest of the question.
Yeah. So thank you so much, everyone, for coming, and we hope to see many of, not all of you, at the next session, which begins at 11.
Yeah.